Good afternoon. I shall be speaking of NORA. Now, when you do a Google search, you get something else. Even on up to date, you said something else. So, what is NORA? NORA is non-operating room anesthesia. It is also known as remote location, outpatient anesthesia, or office-based anesthesia. What does it contain? It contains diagnostic radiology, interventional pulmonology, ECT, ESWL, and endoscopy. Dental anesthesia, cardiac cath lab, obstetrics and labor delivery, obstetrics, especially IVF and labor and delivery are also considered by some as a part of NORA. However, they are not a part of, they're outside the scope of this lecture, as more or less they are like an operating room. What are the challenges which we face when doing a case at NORA? Specific NORA procedures require specific equipment and expertise. It is usually performed by personnel who are other than the surgeon. There is less trained manpower. They may be unaware of problems which are faced by the anesthesiologist. Currently, and as the years go by, complex procedures are now attempted in a NORA setting. Patients are usually old with comorbidities. They could also be children. However, they need a prompt discharge and may not have an admission met if it is needed. Recovery facilities may not be available in several areas, and adverse reactions and CPR are challenging. Managing those are challenging. Now, usually the place where non-operating room anesthesia is conducted are smaller working areas limited by bulky equipment, making access to the patient difficult. They are often remote and distantly located from the traditional operating rooms or the OT complexes. The environment may be unfamiliar. The ergonomics are different. There could be poor lighting because of the needs of the procedures. The position of the patient may be lateral or prone. Equipment usually may be old, may not be regularly serviced. Compatibility issues may be there. Electrical outlets may be insufficient. Pipe gas also may not be supplied even in big institutions. There could be lack of scavenging system. The duration of NORA procedures may vary, and there could be abrupt completion of procedures, thereby adding to the challenges of an anesthesiologist. The risk remains of awareness, airway collapse, and apnea in the patient. Sedation may be given by non-anesthesiologist, and then anesthesiologist may be asked to come when some complications occur. What are the aims of NORA? The aims of NORA is, as always, to have patient safety. There should be amnesia with the patient, less discomfort, pain, anxiety, no movement at critical junctures during the procedures, and safe discharge, and if needed, an ICU bed. This should be the availability. So what is the checklist? It's by a mnemonic called SOAPME. So there should be suction, oxygen, airway, pharmacological agents. P that also stands for positioning. M for monitor and the medicine that should be available. E for equipment, and not to forget the emergency cart. What are the options available to the anesthesiologist? It can be done under MAC, sedation, TIVA, general anesthesia, regional anesthesia. Our anesthesiologist must be familiar to the available equipment at the place, and time-based anesthesia flow sheet must be maintained, even if it may be a NORA case done in any of the options of anesthesia. Sedation, usually many cases are done under sedation. They could easy drift from conscious sedation to deep sedation. Monitoring has to be done frequently, and one with skill and experience knows how to titrate the sedation. So conscious sedation is a drug-induced depression of consciousness during which patients respond purposefully to verbal commands, either alone or accompanied by light tactile stimulation. No interventions are usually required to maintain a patent airway. Spontaneous ventilation is adequate. Cardiovascular function is also well maintained. The sedation can vary from minimal sedation to moderate, deep, and then general anesthesia. So the definition of minimal sedation is like anxiolysis, where the patient responds normally to verbal commands. Moderate sedation usually responds purposefully to verbal commands or on light touch, and the airway is maintained. Deep sedation responds to repeated or painful stimuli. Airway may not be maintained, and general anesthesia is, of course, unarousable to painful stimuli or reflex withdrawal. There are different scoring systems which are done when you are doing a case used for monitoring. The common sedation scoring system, the Ramsay, which varies from 1 to 6, varying from anxiety to no response to stimulus. The other scales are Richmond Agitation Sedation Scale, where the scale varies from +4 to -5, and University of Minnesota Sedation Score for children, with score varying from 0 to 4. Various drugs are used: midazolam, propofol, ketamine, fentanyl, dexmedetomidine infusion, remifentanil not yet, a new drug remimazolone, pedicloryl syrup, and piloxicin, especially pediatric patients. The anesthesia machine, even if the cases are going to be done under sedation or MAC, should be a well-serviced anesthesia machine. In fact, I would say it should be a proper high-end machine, or at least a medium-end machine, in view of being away from the main operation theater areas, and probably most areas would have a insufficiently trained manpower. There should be backup cylinders, oxygen failure alarm, automatic nitrous cutoff system, backlit fluorescent back for the flow meters, and circuits with long timings like Bain circuit are useful. Monitoring. Clinical monitoring plays a very important role, and it's a very challenging if the area is dimly lit and we are away from the, usually we are away from the, standing away from the patient. ECG, NIBP, saturation, and tidal, as always, should be monitored. Pulse rate, pulse volume, pattern of breathing important, and depth of sedation. These are two extremely important when doing a case at NORA. Now, in this COVID-19 pandemic, NORA procedures need a multidisciplinary collaboration. Dynamic guidelines, as we all have seen over the last 2 years, guidelines keep on changing. So they are dynamic in nature to maintain the patient safety and protect the staff. Services of engineering and infection prevention personnel in conducting simulation sessions are needed for the staff. One must delineate appropriate procedure rooms, create specific paths, elevators, and routes for transporting patients admitted for such procedures between floors and ICUs to prevent transmission. Now, coming to specific NORA procedures, MRI. MRI is a non-invasive imaging technique using electromagnetic fields. The indications could be children or for anesthesia in MRI could be children or uncooperative patients, patients with severe movement disorder or mental illness, patients whose position is limited by pain, requiring ventilatory support, and claustrophobic patients. Pediatric age patients could have cerebral palsy, mental retardation, attention deficit hyperactive disorders, and undiagnosed congenital heart disease. They are, in addition to that, anxiety of the parents, which are very extremely anxious parents, challenges to sedate and monitor. Usually feed and rep technique may be done in infants, where the baby is fed, the baby goes to sleep, and the procedure may be done at that time. One must be careful of before taking the patient for MRI. Implanted metallic devices like vascular clips, pacemakers, defibrillators, mechanical heart valves, tattoos, intraocular foreign body, they pose a risk to the patient. Any metal body has a potential for thermal injury from excessive radiofrequency power deposition. The risk is there in higher field whole body scanners, which are more than 1 Tesla. And first trimester pregnancy is a contraindication for MRI. The goal is to ensure the patient remains immobile, calm, and vitally stable during scanning. These are the MRI consent form in some institutes where instructions to patients and patients are questionnaire type thing is there to rule out any metallic objects and any other problems that could occur if during the MRI. Now, there are safety zones which are designated by the American College of Radiology for MRI. Zone 1 is a freely accessible to public outside the MRI environment. Zone 2 is an interface between uncontrolled zone 1 and a strictly controlled zone 3, wherein the patient's history and consent is taken and the patients are screened for ferromagnetic objects on the body or inside the body. Zone 3 is a buffer zone. It is a strictly restricted area. Screened patients are kept in this area under supervision of the MRI department personnel. Even if during the procedure, if there are collapsed airways, anaphylactic reactions, or cardiovascular compromise, they are managed in zone 3. And zone 5 is the MRI room with the 5 years LAN around the MRI machine. So if any mishap occurs in zone 4, then to manage the patient like collapsed airways, etc., you have to move the patient to zone 3. One must be aware when you are giving anesthesia to the duration of the MRI, so that you know how much to give and when to stop. Monitoring equipment is usually classified as MRI safe, MR unsafe, and MR conditional. Anesthesia equipment must be MRI safe. Metallic laryngoscope cannot be used. Plastic laryngoscope with lithium battery is needed. And unconscious anesthetized and sedated patients cannot express pain, which may occur due to burn injury. Unfortunately, there are many areas, many MRI centers which may not have MRI safe anesthesia equipment. The patients can be induced outside the MRI room and transferred to MRI compatible machine within the MRI room. Slave monitors can be kept outside MRI room. To maintain patient airway patency, shoulder roll or towel can be kept below the shoulder. Difficult airway patients can be secured by non-armored LMA or endotracheal tube under J, and pilot balloon should be taped away from the site of imaging and it may interfere. Circuits have to be very long to go into the chamber. Long extension lines for IV lines. The patients are prone for hypothermia, and the contrast used has a very low incidence of anaphylaxis. Monitoring in MRI suite, it is important that direct patient visualization is desirable, however, it may be difficult. MRI compatible monitors are used. The non-MRI compatible monitors should be placed outside the scan room, and cables can be passed through specially shielded holes in the walls. MRI compatible anesthesia moved with piped anesthetic gases must be available, and non-compatible machines must be kept outside the line and bolted onto the floor. Pulse oximeters can have fiber optic cables to avoid burns. NIBP is safe provided connections of cuff and hose are plastic. ECG cables should be shielded and use specific electrodes. The STT changes similar to pericarditis can be visualized due to the magnetic field in MR. So one must be careful before diagnosing anything. It may be completely distorted because of radio frequency energy and static magnetic field. Capnographic, there could be delay in obtaining signal as the sampling tubing is long. Coming to CT scan, it needs usual regular monitoring equipment. It's usually of a lesser duration. Now, modern CT scan machines have lesser duration procedures because the image building is faster than the MRI. Risk of contrast allergic reaction and contrast nephropathy is high. One must take care to prevent dislodgement of breathing circuit and monitoring equipment, especially when there is movement of the scanning bed. Usually contrast media is used, so one must have a baseline creatinine level, as it could lead to some patients may have contrast-induced nephropathy. There could be allergic reaction, where symptoms like skin reaction, airway obstruction, angioedema, and cardiovascular collapse can occur. So one must be prepared to manage such complications if they do occur. The management would be giving oxygen, may need intubation, IV fluids, corticosteroids, H1 and H2 blockers, epinephrine, beta-2 agonist. These reactions can be minimized or prevented by IV hydration, low dose of the contrast media, and acetylcysteine soda bicarb. Interventional pulmonology. The procedures usually done are endobronchial ultrasound, transbronchial needle aspiration, balloon bronchoplasty, airway stents insertion, bronchoalveolar lavages. Usually the position is a hyperextension of the neck. A pre-procedure ABG is desirable. There has to be adequate suppression of airway reflexes. And one must remember that as a delayed complication of rigid bronchoscopy, a tracheal rent can occur and it may present as a delayed complication. So you must be vigilant about it. Usually it is done with using topical anesthesia with local anesthetic. Nasal anesthesia using vasoconstricting agent with topical lidocaine is used. 2% lidocaine with epinephrine soaked cotton balls or are applied in the posterior oropharynx for conscious patient to tolerate bronchoscopy or intubation. They can use the sprays which are also available. 4% lidocaine nebulization inhalation to anesthetize the oropharynx. neural blockade of the superior laryngeal nerve to suppress the cough reflex, and recurrent laryngeal nerve can provide adequate oropharyngeal anesthesia. And one must watch for the last symptoms, that is the toxicity symptoms of local anesthesia. So these are the DAS guidelines when if you are planning to use a topical anesthesia. Usually, if it's done by pulmonologist, he or she may give the blocks, etc. However, if you are planning an anesthesiologist doing, then one must remember the stoppage. The S is small, so sedation has to be very guarded. Then you have to topicalize the this thing, and it is now said that you can use up to 9 milligram per kilogram of lignocaine. Oxygenate the patient well. You can apply HFNO, which is nowadays available at most places now because of this pandemic, and perform the procedure. Now, if there are some complications, then review the sedation regimen or change the agents. Topicalization, if you feel patient is uncooperative, the anesthesia part is not well, then you should give additional if needed up to 9 milligram per kilogram, and one must be watchful and vigilant for local anesthesia toxicity and its management. Oxygenation the patient, you can reverse, increase the FiO2 if need, or change the mode of oxygen delivery. And the procedure usually you allow is 3+1 attempt by a senior person. You may have to abandon the procedure. Suction and alternate route devices must, as a plan B, plan C should be ready for doing such a case. Now, ECT. ECT, electroconvulsive therapy, is mainly used to treat major depression or psychosis. It is usually performed twice or thrice weekly until there is a lack of further improvement. So usually patients need 6 to 12 treatments over 2 to 4 weeks. Physiological effects, it induces grand mal type seizures. The tonic phase is about 10 seconds and clonic phase is about 20 to 30 seconds. There are a few absolute contraindications for ECT: myocardial infarction in last 3 months, cerebrovascular accident, raised intracranial pressure, pheochromocytomas are absolute contraindications for ECT. The relative contraindication would be recent intracranial surgery or intracranial mass lesion, untreated cerebral aneurysm, retinal detachment, glaucoma, cochlear implants, cardiac conduction defects, aortic aneurysm, uncontrolled angina, major fractures, and non-anticoagulated patients with DVT or high-risk pregnancy. These are relative contraindications, so one must weigh the pros and cons before sending the patient for ECT. What are the physiological changes? Cardiovascular, there is a parasympathetic discharge which lasts about 10 to 15 seconds. So there is usually bradycardia, hypotension, or even asystole. So usually atropine is usually given. It could be followed by sustained sympathetic response, which may manifest as hypertension, dysrhythmia, tachycardia, which may last for about 5 to 10 minutes. This may increase the oxygen consumption and increase the risk of myocardial infarction. In addition, there is increase in cerebral oxygen and glucose consumption, raised intracranial pressure, intraocular and intragastric pressures. There could be reflux, esophagitis, nausea, and myalgia. So goals of ECT while providing anesthesia to ECT is there is amnesia and rapid smooth recovery, airway protection, control the hemodynamic response, adequate muscle relaxation, avoid tongue injury, no interference during seizure, and same induction agent is recommended to be used during the entire course of ECT to avoid interference with the seizure threshold. Often, because of the psychological problems, it's difficult to obtain history from the patient, so you need consent from relative. There could be patients could be on several antidepressant drugs, drug interactions one must be aware. Procedure is extremely short duration. Anti-aspiration prophylaxis may be needed. Hemodynamic alterations may occur. The anesthesia drugs should be used which do not alter the seizure activity. Fundoscopy examination is usually done to rule out raised intracranial pressure, and patients may complain of headache, so it's the most common side effect. So paracetamol or NSAIDs may be used as a prophylaxis. So several drugs the patient may be on. It's important to remember that lithium is to be continued 24 hours prior. Patient should not be on MAO inhibitors, could not be continued on carbamazepine, and benzodiazepine if the patient is on, it should be titrated prior to ECT. The common agents used are propofol and thiopental. These are the common agents which are better than other induction agents which are available. Relaxant is a suxamethonium 1 milligram per kilogram. Mouth gag is extremely essential to be inserted, so it prevents the tongue bite and soft tissue injury. Mask ventilation or supraglottic or endotracheal tube. Usually endotracheal tube is inserted. ECT is given and patient is ventilated until the recovery from relaxant event is seen. Now coming to interventional radiology, what radiology I've covered earlier is the diagnostic radiology, CT scan and MRI. Now I'm going to talk about the interventional radiology. The common procedures are drainage like thoracentesis, paracentesis, abscesses, venous access in difficult central lines or pediatric central lines, percutaneous soft tissue biopsies, liver biopsy, kidney biopsy, transjugular liver biopsy, obstructive uropathy, nephrostomy, ureteronephrostomy, uretral stents. So variety of procedures are now done in interventional radiology. Renal artery angioplasty and stenting, cerebral aneurysm clipping, bronchial artery embolization, biliary tract intervention, and tips transjugular intrahepatic photosystemic shunts are done. Now, usually in this setup, the setup is quite, the rooms are big. However, because of the equipment of the interventional radiology, the anesthesia machine is usually located a little away and it's on the opposite side of the radiologist. Radiological vascular access is taken. A retrograde puncture of femoral artery is done. Femoral vein access for placement of IVC filters and venous stenosis may be needed. Internal jugular vein is used for tips insertion. Risk of dysrhythmia is quite high. Radiation minimization protection should be followed during the procedure by using neck guards, lead aprons, etc. Because these are long and radiation is quite high. Other important thing is hypothermia, which may occur because of the low temperatures which are maintained for equipment maintenance. In interventional neuroradiology, there are procedures done are embolization, angiography, and thrombolysis. The choice of anesthesia depends on the procedure, patient's health status, the duration of the procedure. The limitations of MAC doing the procedure MAC is that it could, if it is a prolonged procedure, it could lead to problem, painful procedures, and need to lie motionless. Neuroradiology procedures, usually general anesthesia is preferred since the patient needs to be motionless. The image quality, it also helps in improving the image quality and better control of respiratory and hemodynamic profile. There could be image degradation and interference with road wrapping. So a GA is what is preferred, high frequency jet ventilation if needed, and the shivering, if it occurs due to hypothermia, it interferes with the images, hence general anesthesia is preferred. Anticoagulation may be given to prevent thromboembolic phenomenon due to intravascular catheters. Use of heparin, antiplatelet drugs, and thrombolytics. ACT may have to be monitored, and one may have to be prepared to use protamine, platelets, FFP, or plasmapheresis in certain scenarios. During the procedure, one must avoid acute hypertension as there could be risk of rupture of the aneurysm. Maintain the cerebral perfusion pressure and intramural aneurysmal pressure. Maintain high normal mean arterial pressure to prevent critical reduction of cerebral blood flow. There should be preparedness to perform precise manipulations of mean arterial pressure. One must account for enzyme induction in those patients on anticonvulsants preoperatively. One must control the ICP by manipulating PCO2, blood pressure, intravascular volume. Fewer adverse reaction with non-ionic low or similar regions is usually seen, but one must warn for hypervolemia followed by dehydration. There should be smooth emergence to prevent hemodynamic response and rapid recovery from anesthesia at the end of procedures to facilitate neurological examination and monitoring. So these are very challenging from anesthesiologist point of view. Now, end wave shockwave lithotripsy usually is also a NORA procedure. It causes pain. Patients may have experience claustrophobia, and there could be risk of dysrhythmia. Usually, it is done under MAC. Now, endoscopy, that is GI medicine endoscopy procedures, which are done. A variety of procedures and complex procedures are now being done in several endoscopy suites. Upper GI scopy is done usually for hematemesis, reflux disorders, foreign body, polyps, biliary stenting, and ERCP. Lower GI scopy is done for melena, diverticulosis, colonic biopsy. Endobariatric procedures are done. Endoscopic ultrasounds is done. Esophageal stricture, dilatation, and stenting. Treatment of esophageal varices. Endoscopic mucosal resection. and POEM, that is the per oral endoscopic myotomy for achalasia cardia. These are the common procedures which are being done frequently in endoscopy. However, like other NORA procedure, this also exposes us to several challenges. The airway may be inaccessible in upper GI scopy as the endoscopist is standing at the head end and there are endoscopy screens and monitors there. It could be a semi-illuminated room for better visualization by the endoscopist. Most procedures are done in semi-prone or prone position. Abrupt cessation of procedures occur. Anesthesia for endoscope insertion must be at the time of endoscope insertion must be deep enough to prevent coughing, gagging, retching, vomiting, and laryngospasm. CO2 narcosis can occur as the CO2 is often used to distend the bowel, and there is the risk of aspiration, bleeding, and vasovagal attack. Diagnostic endoscopy usually is done with head-up position. Different positions are used. Colonoscopy is lateral position. Gas insufflation is there into the colon with or without abdominal compression, and that may increase the risk of aspiration. ERCP is done usually in prone, sometimes in lateral position. Endoscopy, if for patients, some patients may need prolonged fasting if there is history of aspiration, pneumonia, or severe gastroparesis or achalasia. During colonoscopy, gas insufflation into the colon with or without excessive manual abdominal pressure can increase the risk of aspiration. And if both upper GI and endoscopy and colonoscopy are planned, upper should be done first to allow suctioning of any residual gastric contents in a semi-reclining position to reduce the risk of aspiration. A pharyngeal topical anesthesia can be done by aerosol spray or gargling. TIVA is often given with drugs like propofol, ketamine, fentanyl, dexmedetomidine individually or in combination, spontaneous ventilation or without airway devices. Remimazolam is a new drug that is approved by FDA in 2020. It's a new short-acting IV benzodiazepine and it is usually given as a slow bolus. It has organ-independent ester hydrolysis of remifentanil while retaining the GABA agonist activities of midazolam. Hence, the name is a combination of remifentanil and midazolam as remimazolam. 5 milligram, it is pushed IV over 1 minute and followed by 2.5 milligram over 15 seconds time after every 2 minutes. If needed, it can be reversed with flumazenil. Endotracheal intubation during endoscopic procedures are done with severe GARD, full stomach, pediatric patients, severe obesity, and patients complaining of with history of sleep apnea. Ventilation should be monitored with capnography during moderate or deep sedation. Airway emergencies like laryngospasm and intractable airway obstruction may occur with upper GI endoscopic procedures. Post-procedure recovery is must and complete consciousness should be ascertained before discharging the patient. Supraglottic airway devices, the new airway which is come up is called as LMA gastro airway. It has a dual channel supraglottic airway device with one lumen for passing the endoscope. This is the endoscope port, and the second one provides an unobstructed airways, and this is the connector which is used. So this you can attach your circuit. It has a bite block. It has the airway tube as I described earlier, inflation live with cuff pressure monitoring, and this is the strap for fixating it. This is the cuff, and this is from where the endoscope channel will exist. It is inserted and removed as for any other supraglottic airway device, and it requires general anesthesia. Complications during endoscopy procedures are common during ERCP, esophagogastroduodenoscopy, enteroscopy, endoscopic ultrasound, colonoscopy, sigmoidoscopy, and sudden hemodynamic collapse is not rare. During COVID-19 pandemic, the upper endoscopy and colonoscopy are considered as aerosol generating procedures. So elective endoscopic procedures are considered to be postponed during the pandemic waves. Whenever possible, endoscopy should be performed in negative pressure procedure rooms. One must use airborne, contact, and droplet personal protective equipment to prevent infection. And GA with rapid sequence intubation and intubation is rapid sequence induction and intubation is preferred. Pregnancy and endoscopy. If you have to undergo an endoscopy in view of the radiation that may be involved and other common issues, second trimester is desirable during pregnancy if endoscopic procedure is needed. Peri-procedural fetal monitoring is essential. Anesthesia management would be as it would be for non-obstetric surgery during pregnancy. Procedural sedation, unsedated endoscopy may be done. Minimal or moderate IV sedation. So there could be different varieties of sedation, different levels of sedation that can be given during the procedure. If a patient is lactating and is undergoing endoscopy under sedation, then the infant should not be breastfed for at least 4 hours after maternal midazolam administration. After 4 hours, breast milk should be pumped and discarded before reinitiating breastfeeding. Now, esophageal dilatation usually performed for strictures. A bougie or a balloon is used. It requires deepened sedation with anesthesia. Endoscopic drainage of large pancreatic pseudocysts requires general anesthesia with endotracheal tubes, and one must discuss with the gastroenterologist performing the procedure about the duration and the other anticipated issues during that. Gastroesophageal fistula are usually treated with clips or glue. It needs general anesthesia with endotracheal intubation, and patient needs to be motionless when the clips are inserted. Procedures are often long and complicated, may involve frequent endoscope changes. Some degree of respiratory compromise may occur due to ongoing aspiration. A common procedure that is done in endoscopy is ERCP, that is endoscopic retrograde cholangiopancreatography. It is done by a scope which has a specialized side viewing upper endoscope. Which is guided into the duodenum. It allows for instruments to be passed through the ampulla of Vetter and into the biliary and pancreatic ducts. Ducts are opacified by injecting a contrast medium, thereby permitting radiographic visualization and therapeutic interventions during the procedure. It is commonly done in prone position. It carries approximately about 5% risk of major complications like acute pancreatitis, bleeding, sepsis, perforation, and there could be high risk of sedation related adverse events. So we usually prefer general anesthesia with endotracheal intubation. Many of these patients would have abdominal ascites, high BMI, COPD. So the complication risk incidence in ERCP is relatively high. Endopaediatric procedures include placement of intragastric balloons and percutaneous gastrostomy tubes for gastric aspiration surgery. Endoscopic sleeve gastroplasty, duodenal jejunal bypass sleeve needs general anesthesia with muscle relaxation. These are longer procedures and the patients are usually of increased weight. So they increase the risk of nerve compression injury and rhabdomyolysis. There could be bleeding and perforation, prolonged insufflation of CO2, and one must need to adjust the ventilation to maintain normocapnia. The POEM is a per-oral endoscopic myotomy. It's done through natural orifice transluminal endoscopic surgery. So this is also called as NOTES. Endoscopic treatment for refractory spastic esophageal disorders. This is POEM is performed. It is done in symptomatic manometrically proven primary idiopathic achalasia cardia or recurrence of achalasia cardia post-surgical treatment. Usually an antiemetic is given as a pre-medication, broad spectrum IV antibiotics. Endoscopic gastric dilatation is done before general anesthesia to remove food remnants and prior to intubation. Esophageal drainage. Intubation in semi-reclining position is desirable with rapid sequence induction and intubation. Position is usually with supine with neck and chest exposed, and the neck and chest, upper chest which is exposed must be visualized by anesthesiologist regularly. Modified rapid sequence induction, maximal paramelysis during the so that there is an optimal endoscopic surgical conditions. Unexpected movement of patient is hazardous. General anesthesia with endotracheal tube and IPPV is done. CO2 insufflation in these are longer procedures, so one must expect pneumothorax and pneumoperitoneum due to the openings in the diaphragm, and be ready to tackle pneumothorax and pneumoperitoneum. ECG, NIBP, capnography, pulse ox, NMT, this temperature monitoring, ABG for serial gas monitoring are usually done. Positive intrathoracic pressure is what is maintained. The optimum CO2 should be around 30 to 35 millimeters of mercury. The hypercarbia would need to make ventilation adjustments or increased with minute ventilation. Proper adjustment of ventilation is required to attenuate elevations in peak pressures. Extubations are usually done after the procedure. However, if there is persistent emphysema, then patients are not extubated. Neck circumference are sequentially measured to track it. Multimodal analgesia like acetaminophen, NSAIDs, opioids can be used. Anti-nausea management also important. Complications of POEM include subcutaneous emphysema, mediastinitis, pneumomediastinum, pneumoperitoneum, pneumothorax, atelectasis, pleural effusion, peritonitis, mucosal injury, esophageal perforation, refluxes, bleeding. Many several complications are seen. However, in experienced hands, these complications are less, and they are managed well by the experienced team of anesthesiologists as well as the gastroenterologist doing the procedure. Now, special position situations in POEM include pediatric patients. There are few case reports wherein pediatric patients also have undergone POEM. They are technically challenging and to be done only by experts. Previous endoscopy and surgically patient has undergone treatment. This adds to the challenges to the operating endoscopist. Sigmoid esophagus in achalasia, spastic disorders, jackhammer esophagus, then gastroparesis refractory to medical films called as G poem. Z poem is called the patient has Zenker's diverticulum and a poem procedure is done. And D poem is if there is other diverticula other than Zenker's diverticulum. So to summarize, there should be a designated NORA team wherever the procedure is done. The team should be well experienced and adequate training should be done for the assistants also, and they should know how to do CPR. Efficient and effective anesthesia is essential. The equipment must be advanced and well serviced. So you often find that you have crores of equipment of MRI and endoscopy and all worth crores of rupees, but you do have a very poor anesthesia equipment. So one must resist in and insist on having a advanced and well serviced equipment for providing anesthesia services for NORA procedures. Thank you very much. I must acknowledge the recently pass out postgraduate students of my department who have really helped me in preparing this presentation, Dr. Janvi, Dr. Sharath and Arvind, on the recent aspects of NORA. Thank you very much.